Um, Hello, everyone. Hi, PGs. How are you? Congrats for getting into ophthalmology. It's an exciting, wonderful, and a challenging field. I'm sure you'll never regret getting into ophthalmology for sure. So today's discussion is going to be a practical topic, a topic on equipment you're going to use day in and day out in your field. I'd probably call it a breadwinner in ophthalmology. A good slit lamp can actually pick up a lot of many diseases. Many of them very subtle. It can be picked up much early in the course of the disease. So all it needs is some tips and tricks, how you can pick up some subtle findings and how we can do a good slit lamp examination. So today we're going to see something about it, and we're going to see something about a cool topic. So just sit back, chill out, relax, and then enjoy the talk. However, remember, I'm going to give you some tips and some questions hidden in this for exam questions hidden in this talk. So do pay attention to make sure you catch all those questions. Okay. So let's go into the talk itself. My window's narrowed. I can't see my view full screen.
You go to the top slideshow.
Top slideshow hidden by the bar.
I can see it from here.
Yeah, okay. Maybe I've got a bar blocking it. Okay, no worries. I'll get it out.
From the beginning.
Yep.
Go to the left.
No, it's actually gone into the.
Do one thing. Give me the remote control. You just allow me to control you.
Yep.
I've done it. You've allowed it?
Just a minute. All this has gone into the Windows mode.
Yep. Siraj,
Yep.
You can allow me.
Yep, I'm just doing it right away. Hold on.
You got it? Just say yes. When I send you a message, you just say okay. Did you get my message?
Yes. Yep, done. I've got these pop-up boxes blocking my view. Thanks, Dr. Rajiv. Thank you, so kind of you.
Yeah.
Thanks.
You can continue.
All right, so now here we go. Okay, so I thank the esteemed faculty of the KSOS, Madam Meena Chakravarti, Dr. Mahesh and Dr. Rajiv Sukumaran for giving me a chance to be here. And of course, I would like to thank Dr. Freddie Simon and Dr. Sija for the same opportunity as well. So I start with paying respects to my teachers, but for whom you wouldn't be what you're here. So as postgraduates, please remember that you should always remember and respect your teachers. And when you become teachers, make sure you carry on the good information and the good work your teachers are doing now. All of them are spending a good Sunday for you. And you know when you start practice how valuable a Sunday is. So I have no financial disclosures. I acknowledge all the sources of internet information which are used for purpose of teaching only. And it's not an exhaustive review, but it's just to kindle a kind interest in the subject. So this is how I plan to go through it. Some basics, some types of examination theories, some special situations and procedures that could be done in a slit lamp. And also, we can also talk about do's and don'ts and how to take care of a slit lamp. And that's very important as well. So a slit lamp for an ophthalmologist is like a stethoscope to a physician. So it's of three parts, which has been well covered, which is of the optical system, the illumination system, and it derives its name from the slit lamp biomicroscope, which means the lamp is here, which creates a slit and viewed by a biomicroscope. It's by Gulstrand who introduced the slit concept, and it's really evolved from the primitive stages to what it is now. So we have the basic model, we have the photo slit lamps, we have the portable slit lamps. We do have accessories which are there, which can be used with the slit lamp as well. Lasers can also be used with the slit lamp. And it's basically three components: the structural one, the illumination one, and the observation. So in the examination, they ask you about the function of the slit lamp. This is how you have to talk about. And similarly, when they talk about each setting they use in a slit lamp, remember to include A, B, and C for each of this particular view you're going to talk about. So it has the structure and the three parts: illumination and the observation. The structure is made of the forehead band, where the patient rests the forehead, the chin rest, where the patient keeps the chin, the adjustable height, the hand grip for the patient, the fixation light where the patient looks at, and the joystick controller to move the slit lamp, and also the lock for the slit lamp. And when you have this is the joystick which moves in different directions: right, left, top, and bottom. And also we have the canthal marker here where it's important that the patient align the lateral canthus with this for you to get a proper view. It's important to make sure the forehead is pressed well and the chin is pressed well. And this position makes your life very easy. This is a common mistake people do when they're learning the slit lamp. Make sure the patient is seated in this position before you start. Your life will be really easy. Similarly, we have a top light illumination system and a bottom light illumination system. The rheostat and the switches are the one which is important, which starts the light. We do have the light source. We have the display in millimeters to indicate the length of the light. We have the different filters, height adjustment knob, and the swivel, which will swing the light horizontal, vertical also. So when you have the filters, we have different kinds of filters available. This is an overview of the different types of filters which you should remember in the examination. We'll just see a few of them as we go through. So cobalt blue is a filter which is used to illuminate when you use a dye called FLOURESCEIN, and this picks up in a contrast areas which are denuded in the cornea. We do have neutral density filters. For example, here if you see the light is flooded, when you use this filter, subtle changes like the vessels can be picked up better. So neutral density is used to decrease the amount of light so the patient is comfortable and also pick up subtle changes. The reflecting mirrors are the ones which direct the light from the lamp into the patient's eye. They have two types, the bottom and the top. A point of note, the top one has a front coated mirror. Unlike the mirrors in your house, this mirror is coated in front. So which means you're going to wipe this mirror every day. You're going to take out the coating. So remember, if it's dust, you should blow it. We should not wipe it with a rough cloth. We have a column tilt function. What it means is the light is usually vertical. You can also tilt it so that we can see different deeper areas of the eye, like the fundus examination, which will be dealt with a bit later. So when you tilt the slit lamp, it tilts this way. Remember, this is possible only in the top illuminating light system model. How you do it? You've got a small knob here and a knob here, and this knob is released. When the knob is released, it shifts off axis. In addition, we have a knob here which tilts it on the oblique axis, which is used in special circumstances, which you'll see later. The third component being the observation system is the binocular system, where you see with both eyes to see a single vision. You have the magnification factor here, and this is very important as well. You should always remember to make sure either your refractive error is corrected in the eyepiece. It could be different in each eye, or you connect it to 0, and then you can focus with your joystick. This is another common tip which is important for beginners. Magnification system. Why do you need a magnification system? You see the eye from here. It can slowly magnify based on the extent of the magnification factor used for deeper evaluation of a particular tissue. So let's recap what we have learned. We have learned it has structure, illumination, observation. Structure has an objectival frame, the framework, and the chin rest. Remember the alignment part. Illumination has the light, the rheostat, the different filters, vertical height, horizontal height, oblique height, tilting. And the observation system, which has a binocular system, remember you should make it 0, 0, align the interpupil distance, and get the magnification to the minimum before you start, so you get a broader perspective. Now that we know how the basics are, let's go slightly forwards. Before you start, remember to clean with alcohol wipes. Make sure the instrument is clean between patients. Make sure your seat is comfortable. Patient's seat is comfortable. A small tip, try to avoid using chairs with wheels for the patient chair, because there have been instances, especially obese patient, when they try to sit down, the wheel tends to move. So it's better to have a chair which is fixed. Chin rest paper ideally change between patients. Barrier precautions because of COVID. We have to use barrier to make sure you're safe. That's very important. The illumination system, remember to check the filters, make sure it's not in the wrong filter. Beam specs to keep it minimum, and start with the lowest illumination. So like starting a car, keep it in the lowest illumination before you do. Observation, get into 0, 0, adjust the interpupil distance, and keep it at the low mag before you start. Once you do this, you're ready to get started. Barrier is important. Remember, barrier precautions are very recommended for protection, especially in this season. It can also be continued later for your own safety. Positioning, ideally sit seated so that you don't couch behind. The patient is also comfortable. You're also comfortable. Remember your patient's canthal angle, as I mentioned earlier, the forehead and the chin to be aligned. This is very important for you to have an enjoyable slit lamp experience. The rheostat starts the engine, and then there it goes, and you have all the settings which I told you earlier. Always remember to get the beam away from the eye. Don't keep it on the eye. Keep it full light, then start it in wide go. Patient gets startled. Before you start again, remember your hand. Okay, one hand is on the joystick, one hand is on the light. So that if you are used to the slit lamp, you're not supposed to take out your head, look where the settings are and go. It's like driving your car. When you drive your car, you know where your gear is. You don't look for your gear every time you change your gear. Like that, if you're used to a slit lamp, you know where the settings are. One hand, whichever depend on your dominant hand, one hand is on the joystick, one hand on the illumination, which will tilt the beam, at the same time adjust the width also. Okay, look here, one hand on the joystick, one hand on the illumination. And when using special lenses for retinal examination, which they'll explain later, you have to hold it in this way. Remember that you should support your elbow so you don't have pain here. Otherwise, at the end of the day, you lose a lot of slit lamp, you go home and you say, I'm tired, I get pain here. That means your ergonomics is wrong. Get your ergonomics right. That's very important. Learn it from the beginning. So now that you know what to do, how it is done, you see what are the types of visualizations you can do. So we have direct types of visualizations and indirect ways of it. Direct is just where you actually look. Indirect is you put the light somewhere and you look somewhere else. Let's see one by one. When they ask you in the examination, different types of illumination, this is a common structure you can use. When is it used? When you have to use in clinical situations, what is the light source and filter? What is the angle you have to keep it? What magnifications? Special precautions. The tip is even if you don't know anything, you just remember this very well and write it down. You can fill up something, you still get some marks. It's a shortcut anyway. Okay, so diffuse illumination. How does it work? It's like a torchlight. If you want a torchlight to see the eye, this exactly is diffuse illumination. This is a view from the top. This is how I placed it. If you view the from the top, this is where your eyepiece and head is going to be. This is where your light is going to be. If I keep the light here, that means your left hand is holding the illumination. The right is holding the joystick. That's what it means. If the light is on the right side, your right hand is going the light and the left is going the joystick. Make sure you're ambidextrous. It'll be helpful when you're doing your precos later. Okay, so this is diffuse illumination for you. Right, so why is it used? To get an overall impression of the eye. Clinical situations, you just see the lids, adnexia, whatever's on front, whatever's externally you want to see, that's what you use it for. Light, white light or yellow light, preferably a diffuse filter, which was already explained very well before. Angle along the filter, and it swings along with the light, sometimes in the side, sometimes in the straight. Magnification is lowest because you want to see a bigger view. Higher the magnification, smaller the view. Lower the magnification, bigger the view. It's like seeing a forest from the top in a helicopter. It's very comfortable for the patient. You just quickly scan left to right. Very quickly you can do it. Okay. This is a diffuser. You put the diffuser in front, it becomes in a very diffuse way. It can be done with a diffuser like this, or you can use from the side, or you can see, this is how you can see. For example, if you turn the lid over, this is how you see inside the tarsus. And this is how you can see the lid margins. So this is helpful to find out gross lesions. If you don't use a diffuser, you can still use your normal spot, but make it big. But you see a round one, you won't see a diffuse area, but you can still make it out. So this is how you use it without a diffuser. That was diffuse illumination for you. One already ticked. We go for the second one, which is a focal illumination. What is it? You're going to see a single portion only. A focal illumination allows you to see one part of the eye only. Okay. So it can be like an optical section. You see, this is like a section. Suppose you take the eye and you cut it. This is how you'll be seeing it. It's an optical section of the eye. And then what do you see? Corneal lesions, anterior segment, lens, vitreous. You adjust the width. You can get it very fine. You can get it medium. Usually it's from the side. And the magnification slowly increase it so that you can get. Remember, if you're going to keep it for long, if the illumination is too bright, the patients will not be too comfortable. Let's see some examples how it works. A narrow beam here, a moderate beam, and a broad beam. This is how we quickly see. Here I show the different height adjustments of the slit lamp. You can see the swinging of the slit lamp. If you observe, the pupil constricts when the light is more. So that means that more light is going in, patient is going to have some photophobia as well. So this is in average a quick overview about focal illumination for you. In focal illumination, you can make it a very narrow slit. A very narrow slit for conjunctiva. For example, this is a lesion in the conjunctiva. It looks like a solid lesion, but if you put a slit, you know it's not a solid lesion. Sometimes you can also see the cornea. Light is coming from this side, remember. This is the front, this is the back of the cornea, this is the iris. So here is an example. This is a foreign body in the front of the cornea, anterior to the cornea. This is how it looks. Anything in the back of the cornea will be behind on this side of the slit, like keratic precipitates here. Or a corneal ulcer, you can see the slit changing its shape here. In a corneal ulcer, when this thing is uniform or keratoconus, the shape goes out, you can also study the shape of the cornea at the same time. Okay, this is a grading of the anterior chamber, another exam question which you have to know. Next, we go for the lens. So see, again, the light is coming from here, the front of the lens, the different layers of the lens which you can see clearly. Okay, sometimes you can go for a moderate beam, slightly more broader. That will give a more information for you. For example, if I use a moderate beam of the same condition, which is decimus membrane folds, a moderate beam gives the distance of the extent of the lesion, whereas the slit gives the extent of the depth of the lesion. You can see here, this is the front light coming from here. This is the front, this is the back. You can see the folds in the decimus here. So this is the difference. So you can use this for certain circumstances, moderate for certain circumstances. You can pick and choose. Then you go for the anterior chamber. What do you look for in the anterior chamber? When there's inflammation of the eye, then leads to some cells formation. Eye is the only organ in the body we can study live physiology directly. And this is one of such physiology which you're lucky to see. This in good magnification, proper light, proper 4 mm by 1 mm setting, you can see the cells here. You can see the cells in dynamic motion. So this is how you see the cells. It's by an effect called Tyndall effect, where you can see the cells moving because they reflect the light back onto you. In a section, you will see the cells here. And when you need to see the flare, this is how we see the flare. This is again another exam question. They'll ask you how do you grade the cells, how do you grade the flare, when you get them, what to differentiate and how to differentiate the two. Okay, but I'm just my idea is just to give you an idea how it looks like. So we have a broad beam, we have a narrow beam, we have a spot evaluation. A tangential beam is when you go further away. When you go further away, you can see the tangential study of the iris. Like for example, if the light is coming 90 degrees, it's like somebody keeping a torchlight like this and evaluating the iris. When you see the depth of the AC, this is a tangential beam for studying the iris. You can also see some nice, beautiful nodules in the iris, abnormal vessels going on in the iris as well. See here, when you see, all you have to do is very quick one. You just have to quickly scan from one side to the other. If you spend the least time across the pupil, when you go across the pupil, just go across. So you just go left, right, top, down. That's how quickly you scan if you want to scan the surface of the iris, for example. This is an example of how you do a focal evaluation for a quick overview of what's going on. Indirect examination is when how he's using it is anything close to you, shine a light and see just close to the lesion. So you can adjust the breadth of the beam. This is how you see any lesions close to it by the side scattered light only. It may get a bit uncomfortable for the patient. Another useful one is called retro illumination. As the word goes, it's back, illumination from the back. So you shine a light here, it goes all the way to the retina and reflects back onto you. And that view gives you an idea. This is an intraocular lens, which you can see here, the backdrop of the retinal red glow. So what does it do? Anything close to lesion, corneal section, it's adjust the breadth of the beam, slight angulation or usually axial, and you have to increase the magnification if required step by step. And it can get uncomfortable because the light is going to go all the way into the retina. So for example here, this is how retro illumination looks like. You can see in the background of the iris, you can see the nice, beautiful blood vessels. Okay, let's compare. This is the same picture by diffuse illumination on the left. You see, you can see the gross extent of the lesion, but the retro illumination gives you an idea about the extent of the blood vessels, extent of the lesion. This is how retro illumination will come into use for you. Retro illumination can also study fine corneal vessels, nice, beautiful sutures, the depth of the sutures, the extent of the involvement, iris window defects, atrophies, posterior capsular thickenings, decentration of the IOLs. So this is what retro illumination is useful for. The next one you go for is specular. Specular is speckled. So specular reflection usually is used to see the endothelium. Can be done for other layers as well, but for endothelium. How does it look like? The light goes from one side, gets reflected like a mirror from the endothelium, and in high magnification, proper lighting, still patient, proper fixation, very quick examination, you have to do this. This is very useful if you're doing a cataract preoperative evaluation, because if the endothelium is not healthy, later when you do a cataract surgery, the surgery could go wrong. Okay, so specular examination, think of endothelium, think of high mag, still patient, high illumination, and a proper quick reflection off from the endothelium. Okay, so we've seen quickly diffuse, you've seen focal, you've seen tangential, you've got retro, you've seen indirect. Now you're going to see sclerotic scatter. What is sclerotic scatter? Sclerotic scatter is when you decenter it away, one goes away from the other. Use a knob here, which is seen here. This knob, you decouple the knob, and then the axis tilts. You see here, this is not at right angle. This is tilted away. This is what you look for. How does it look like? I'll give you an example. This patient comes to us with inflammation of the eye, recurrent inflammation. You see a white area here. You don't know how much is the extent of involvement, okay? This is diffuse illumination for you. In diffuse, I see this is a problem. Then what I do a sclerotic scatter. I shine the light on the side. Now you can see the extent. How does it work? The cornea is like a clean mirror. You have those fiber optic cables, internet. So cornea works like a fiber optic cable. When light goes on one side, it gets internally reflected, goes all the way and exits from the other side. You see, light goes here on this side, exits from this side. When it's traversing here, there's no opacity, it's very clear. When there is an opacity, it reflects back onto your eyes, and that's how you pick it up. So it's, they'll ask you total internal reflection principle, scattering of opaque media, any media density. These are some catchwords you have to put in the examination. Okay, so this is how you can pick up in a sclerotic scatter. Later, you can further go deeper inside and check the vitreous as well. So you can see here, this is the iris, the front of the lens, the back of the lens, and anterior vitreous opacities. So we can also check the vitreous and also check the fundus with use of special lenses, which will be dealt with later. But fundus examination stereoscopically, unlike a direct ophthalmoscope, stereoscopically, we can see a beautiful fundus examination with a slit lamp. And other procedures can also be done. Subtarsal foreign bodies, some small procedures can be done in a slit lamp. Okay, so this is quickly an overview about what all things can be done. Let's see some practical examples how we can put it into play. This patient came to us as a referral as a deep stromal foreign body in the cornea. When we see in diffuse illumination, it doesn't give much detail. So what we do, we go for iris retro illumination. Look, you can pick the foreign body like a dark in the background of the bright illumination. So what do? You have to remove it. The foreign body was removed. Now comes the question, have I removed it properly? Is there anything left behind? So how do we check? The view didn't give me any idea. So I go back to retro illumination. Here you can see beautifully, this retro illumination gives us an idea that the foreign body has been totally removed. So this is how practically in your setup, you can use it. You don't have to go through 1, 2, 3, 4, 5, 6 for every patient. You do 1, 2, then you decide which one you have to do, and then you follow up. Like for example, this patient came with drop-in vision. He's got a whitish lesion here. Where is this lesion? Is it in the cornea? Is it in the lens? I don't know. So I do a focal slit examination. I can see it's in the lens, the front of the lens, the back of the lens. So I know this is the back of the lens. My next question in my mind, how big is it? Is it just a small or a big one? Then I go for retro illumination. You see? So I saw a diffuse illumination. I quickly jumped into focal. I saw the depth. I quickly jumped into retro. I can see the extent. So this is how you have to learn and play around with your different settings for your slit lamp. Okay, see here again, this is how it gives you an idea about the extent of the lesion. Okay, this quickly is an overview just to see the different kinds of setup. But then not all images or not all structures can be very clearly visible. Sometimes you may need a contrast. You see, when you do a histopathology slide, you put stains because without the contrast, you can't pick it up. Here we use stains as well, but these stains are called vital stains. So why are they called vital stains? Because you put them when the patient is still alive. Okay, so what then again, this I'll give you another shortcut. These are the broad framework to use when they ask about stains. You know it or you don't know it, just memorize this one first. What are the stains? Why to stain? What are the types available? How do they work? When to use them? When not to use them? That's also important. How to use them and what should you tell the patient? This is practical point of view with the last one. So this is in general, all you have to do is fluorescein. Remember two things. Fluorescein stains when there's a tissue which is denuded, no tissue. Rose Bengal and LISSAMINE stain when the tissue is damaged. Both do not stain when the tissue is healthy. Point number 1. Point number 2, fluorescein, you have to use yellow filter. Whereas Rose Bengal and LISSAMINE green, you can use white filter. Point number 2. These are shortcuts. Point number 3, Rose Bengal, as the name suggests, is rose, red. LISSAMINE green, as the name suggests, is green. And fluorescein is between the two, yellow. Okay? 3 things, whether you know or not, whether you remember anything or not, you just write this, you'll get at least 40% marks. Okay, fluorescein stain is used when it uses the principle photoluminance. Certain catchwords you have to remember. What happens when light is shone on it in one wavelength, it absorbs it and exits it in another wavelength, a longer wavelength, which means blue goes in, green comes out. Okay, this is when the phosphines are excited and they release it upon stoppage of the light or when the light is still on. There's a difference. If you're really interested to get more marks, they'll ask you about fluorescence whereas phosphorescence. Fluorescence is a property, as long as light is coming, this light keeps going. You switch off, this goes off. Phosphorescence, you keep shining, you stop the light, it still keeps fluorescing. That's phosphorescence for you. Okay, let's go back to this quick one. So this is used only stains the damaged tissues. It has a use of phosphines and it exists. Blue goes in, a lower wavelength, yellow comes out, longer wavelength of green comes out. What filter do you use? I showed you earlier. Blue filter. You have to excite. It's called an excitatory filter. It also blocks the returning blue light coming out. So what do? You have to use it, and specific indications were diagnostic, therapeutic, like Goldman, contact lens fitting, checking up some partial papillae and wound leaks. Let's quickly see one by one. Tarsal papillae, if you see the image on the left, is not very clear. You put a stain, you can pick up some contrast that gives you a contrast. An abrasion patient coming to you, you stain it, this is how it looks green. But you put a blue filter, you see the contrast it gives. Another example, this patient came to us with recurrent irritation, foreign body feeling, not feeling comfortable. Diffuse illumination doesn't give you much. You stain him, then you know it's a case of recurrent corneal erosion. This is a dramatic way and you can diagnose better. That's why you have to use a stain. Another point, remember this patient, any patient seeing an isolated abrasion, complaining of foreign body, please remember to evert the lid. This is a subtarsal foreign body here, which has been causing scratching here, causing an abrasion there. So remember always, no examination is complete without everting the lid. Remember that. Sometimes what happens when there's a leak or a damage, then you put the fluorescent stain, the fluid coming out will change its color. Like here beautifully you can see, when there is a leaking going on here, by applying the fluorescent stain, the leak, it's called a seidel test. Another exam question, seidel test. Where do you use it? Trauma, post-trabeculectomy. You feel the AC shallowing after surgery, you put sutures, you're not sure if you've done the sutures. Corneal transplant, you put a suture, you're not very comfortable, you think it's leaking. To know if it's leaking or not goes your seidel test. Okay, another exam question for you. So this is also called a breakup time. Normally you don't see tear film. Tear film is transparent, right? So now if you want to see a tear film, you have to stain it. So normal tear film, when you blink, it remains in the front of the cornea, keeping it cool, like your car windshield wiper. But some patients, it becomes dry very fast. So those patients are not comfortable. They call them dry eye patients. So how do you know they're dry eye patients? Is you have to stain the tear film to see how it's working. So by putting a drop of fluorescein, it stains the tear film. Then the tear film, as long as it's in contact, it remains green like this. But when the tear film dries out in certain areas, you can see, you just watch here, it'll become black. So this is where the tear breaks up. So you have to assess the time where the tear breaks up. It's called the tear breakup time. So the tear breakup time is very small, then the eyes are very dry. So the purpose of fluorescein is to assess the tear structure, tear integrity, tear breakup time, and the tear flow. All right. So this is tear breakup time for you, one of the uses. Sometimes some irritation can be there. You can use a stain to see where the subtle changes in the cornea are. And for contact lenses also, you can put a contact lens, and this is where you can see the film of the thing under the contact lens when it's blinking. It's called a Jones test. So when you put normally the tear film is flowing out. When the tear is flowing out, you can see it draining out and it's positive. But sometimes what happens, the tear doesn't come out really. Then you put a stain, you flush it out, and then you see here. So it's called a Jones test. All you have to know is it assesses the tear flow function. In small children, you know the tears are flowing out. Just put the drop and you assess it coming out. Or in adults, you put it here, test it here. You know, if people would have felt, put eye drops, you feel in your throat. That means your tear duct is normal. This exactly is the same principle. If it comes out here, it's good. If it doesn't come out, you flush it. It's called Jones test 1, 2, which you can probably lead up later as you go through your course. Okay, it's also used for other procedures like Goldman, which again they'll discuss in the glaucoma subject. How is it available? So small practical point. It's available as strips, is available as minims, which is preservative free, available as reconstitution. Most of us, we use reconstitution when we were students, but the thing is, reconstituted solution, the problem is it doesn't have preservative. After 24 to 48 hours, it can get pseudomonas. So it's here to be very careful to make sure that you don't touch the tip, you don't contaminate the liquid. Sometimes if it's old, please don't use it, because the patient comes to you with corneal abrasion, you're going to put this drop and give him a corneal ulcer. So remember, if the fluid is there, if you make sure it's clean and fresh, otherwise please don't use it. The safest one is this strips or minims which are preservative free. Rose Bengal, almost similar, everything similar, just follow the same, except it stains only damaged tissue, not denuded, doesn't stain normal tissue. Remember that. The forms are the same, 1, 2, 3, you can fill the same. Used in dry eyes. Okay, again, dry eyes. But you have to remember one thing, patients will have a lot of burning. Rose Bengal, remember burning, B for B. Rose for color, B for B, burning. Okay, when a patient is wearing contact lens, don't put it. He's going to be after, he'll kill you because you're going to stain his contact lens. So remember, any stain before you put, ask the patient, are you wearing contact lens? Soft lens. Soft lenses you cannot put. Okay, then how does it stain? It stains red and is using a white light. Some examples here. You can see here how it's stained. It also stains corneal tissue. Like here, for example, herpetic. When it's herpetic, you see these cells are damaged, which is stained. The fluorescence stains the bed. The fluorescence stains the bed. Then the Rose Bengal stains the margins. Okay, right? You can also use both to, it's called dual staining. You can use both to get a better picture of what's happening. Quickly, okay. So you 1, 2, 3. Lissamine green. Exam question. What is the color? Lissamine green. Green. The exam name will say, what is the color of lissamine green? That is, catch the catch. Okay, lissamine green. Now, how does it work? Same. Minims, constitution, all the same. I told you the broad skeleton. So the shortcut is you just remember the skeleton. 40% you can write. And then once you remember the skeleton, just remember what is it different in each of it. Just remember that. So all you have to try to write the skeleton, see what's different, and put it inside. You'll still get it. Okay. So conjunctival stain and dry eyes. This is more comfortable for the patient. That's how it's different. Cannot put on contact lens. It's green in color. Just 3 points how it's different than rose Bengal. Okay. So it's also useful for a condition called lid viper. This happens in dry eyes. The epithelium has become changed in their architecture, which will take up the stain. So any patient with irritation, always flip it up and look inside for foreign body, tarsal papillae. If required, you stain the margins. This will give you a lot of idea. Now for common mistakes, what you should not do. Look here. Here the patient is not keeping the forehead. I told you the most important thing which will make your life very easy. This, and this. Make sure your duct is done and the patient is comfortable. Your life is very easy. You can get very good examination. Very easily you can do. Remember, you don't slouch back. If you don't want to go back with a back pain, don't do this. If your chair is not good, don't challenge yourself. Make yourself comfortable. Never do this to the patient. Don't keep the light full. I told you, remember, always keep the rheostat low, switch it on with the beam away, then you bring. So patient will be confident. Otherwise, patient will be scared whether they're going to hurt the patient. When you're doing procedures, another tip. Sometimes these procedures you do when you go close. Difficult to gauge 3D. So what do you do? Sit from the side, view the slit lamp and just move the slit lamp close to the patient, just 1 inch away. Then you start focusing and do it. It's like a camera. You have a huge zoom lens. You cannot do fine focusing all the way for a tree away. You just do the main one, then you do the fine focus, the same thing. You move a slit lamp, see from the side, go close to the patient. Patients also trust you. Then you go to the ocular, then you move side to side, very comfortable. Sharps, never keep the sharp pointing towards the patient and go with the slit lamp like this. Very dangerous, remember. Keep it away, rest it on your frame. Do it. Once you're confident, bring it into your field, then slowly go in. All right, there's some small tips which is important. Remember to sanitize all points, ensure barrier protection because you make sure you're safe. Make sure they reset the thing at the end of the day, low light, so that the next examiner, next patient will be okay. Dust protection, don't use strong caustics, mirror care, I already told you. And always remember, this machine will be used by different people. When you sit, organize it and set it for yourself before you move. It's like when you move to somebody, your friend's car, you adjust your seat first. You don't go by there sitting and drive it, right? You set and adjust your seat first before you drive. That's exactly what you should do. And the most important, we've got an excellent panel of teachers with you. All of them very patient and willing to help you. All you need to know is go and ask them. Go and ask them, tell them your problems, just keep practicing. And another most important thing which I did when I was a student, you sit in front of the slit lamp first. You sit, ask your friend to examine you. 2 things you will know. 1, how uncomfortable it is to sit in the slit lamp. 2, how much the light can be so bright. Once you do that, you're going to be empathetic to your patients. Patients will cooperate longer. Keep practicing, practicing, practicing. I'm sure you guys will do well. Thank you.